Hi, it's really an honor to be here. Thanks for having me. I'm Anne. I'm a pulmonary and critical care fellow physician at the University of Pittsburgh. And today I'll be discussing the epidemiology of pandemic science at JAMA. So there's no funding or support to report, and these are the conflicts of interest for authors. So the idea of this project really germinated initially during a socially distanced coffee meeting in the fall of 2019, when we were really marveling over and discussing the incredible response by clinicians, scientists, and public health experts in the face of a novel and really overwhelming pandemic, as you can see just here by this map of COVID-19 disease burden around the world. We knew that there was an unprecedented volume of COVID-19 focused scientific output, but we were wondering what the relationship between pandemic scientific output and disease burden, especially in characteristically underrepresented regions, was, and what was the dissonance between output and disease burden when adjusted by population. So to answer this question, we developed a cohort study for research submissions with JAMA editorial staff to describe the epidemiology of pandemic science through JAMA submissions. The non-pandemic cohort included all submissions to JAMA from January 1st, 2019 to December 31st, 2019. The 2020 pandemic cohort included research submissions to JAMA from May 1st, 2020 to April 30th, 2021, identified with an electronic query of COVID-19. We use this timeframe specifically as that's when JAMA Network first began tagging submissions electronically. And then the following article types were included as pandemic science: clinical trials, meta-analyses, original investigation, research letter, and brief report. And we excluded JAMA Network journals. Data on COVID-19 infections and deaths were sourced from WHO situation reports and analyzed by epidemiologically defined WHO choice subregions. As you can see on the map here, we have the WHO choice subregions: Africa, the Americas, Middle East, Europe, Southeast Asia, and Western Pacific. Also shown are additional population data, population per millions, life expectancy years, and gross national income. These subregions were used as a surrogate to classify resource-rich and resource-poor areas, as these subregions have previously been used by the UN and the WHO for resource allocation. They're grouped A through E according to adult and child mortality, with subregion A having very low rates of adult and child mortality, and subregion E having very high adult and child mortality. And of course, we can see that the largest disparities are between the A subregions and other non-A subregions. So what did we find? Moving on to the results, here we have a table by article type for the pre-pandemic cohort and the pandemic cohort, with the total number of submissions per time at the bottom. As you can see in the pandemic cohort, JAMA research submissions reporting on COVID-19 were greater than the entirety of submissions in the pre-pandemic cohort. The difference between pre-pandemic and pandemic submissions was the greatest for the research letter type. And this is just to highlight that. Next, let's examine the temporal relationship between pandemic science submissions during that time frame and COVID-19 cases. So this is a graph with time on the x-axis, pandemic science submissions on the left y-axis as represented by the bars, and COVID-19 cases on the right y-axis as represented by the line. We see that pandemic science submissions tended to follow increases in disease burden. And then we wanted to know what these pandemic science submissions look like when mapped according to the subregions. So here we have a map of the pre-pandemic cohort on the left and the pandemic cohort on the right. So what you'll notice is that each map has several size bubbles, each representing different types of article submissions, with size correlating to number of submissions. I'll highlight a few points here. In both cohorts, the Americas A had the most submissions, followed by Europe A and Western Pacific B, mostly from submissions from China. In the pandemic cohort, there's a decrease in clinical trials and meta-analyses from all subregions. And during the pandemic period, there were fewer than 50 pandemic submissions from Southeast Asia and fewer than 10 submissions from Africa. So all in all, we see that the balance of pandemic science type, original investigation, research letter, and brief reports were fairly similar across all regions. And then last, to account for population differences, we examined population adjusted pandemic science submissions for each sub-region. So to calculate these, we use population data per sub-region divided by submissions per million people. And you can see here that the Americas A and Europe A had the highest number of adjusted submissions. We actually excluded China from the Western Pacific B region because of its unusual characteristics of low disease burden for a very large population. So we found that pandemic science submissions to JAMA exceeded all pre-pandemic JAMA submissions. And while most submission types increased during the pandemic, there was a decrease in clinical trials and meta-analyses from all subregions. Resource-rich subregions, such as the Americas A and Europe A, produce a majority of COVID-19 related scientific output. There are a few limitations that I want to mention. The first is that analyses were restricted to JAMA, not all network journals. Of course, WHO data is self-reported and may not actually accurately reflect disease burden. And these COVID-19 studies were found with an electronic flag and subject to some misclassification, although there was a manual adjudication process. So discordance between disease burden, subregion status, and scientific output may be due to lack of established scientific infrastructure, inability to quickly respond to emerging pandemics, and potentially submissions to alternative journals. In conclusion, what we may see is that COVID-19 science may be less generalizable in lower income regions, and that further work is needed to explore this difference. Thank you.
Thanks. Questions for Anne? And the bright lights, we can't see. People, IRC. Right, we are being blinded up here. And I should point out that Anne's slides that she was looking at didn't correlate with what she had to speak about. So the presenter view was completely off. Weren't looking. Okay.
No.
Yes, it was someone else's talk. And anything online, Michael? Nothing yet. Okay, so let me ask a question then. It's interesting to think about the correlations with income, which obviously are correlated roughly with the volume of medical research being done in those areas as well. So if you did a correction and said, how many researchers are there or how much is the total expenditure on research, does that correct away all the volume differences?
I think that's an interesting question, and I don't know how to answer that because I don't know if that database exists. We tried, so we looked at different ways of classifying regions. You know, we looked at where the first author was from, where corresponding authors were from, and then we ended up using where the corresponding author was from to label where the research came from. Of course, in this day and age, there's a lot of crosstalk, multinational studies, and we didn't have a great way for adjusting for that. So if anyone has any thoughts or ideas on that, I would be welcome. I would be happy to hear them. Mm-hmm.
Okay, if there's nothing else, thanks, Anne. Let's go on to our next speaker.